The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. Tonight we're going to do a podcast on neonatal heart disorders, and we're going to kind of look at a case or two regarding that. We're actually here in Temple, Texas, doing a review course. Just got back from Europe, Germany specifically, did a review course for U.S. Army Special Forces, and got my brother in arms, Mike, with me, so he's going to help narrate and host the podcast as we go through. So how you doing, buddy?
I'm good, man. Good to be back on the road with you. I hope you had a good time in Germany, and everything seemed to be pretty good. So
yeah, it's going good. It's
hot
real
here.
Warm here.
Oh,
yeah,
my Lord.
Hot wind.
A hot wind.
It's a hot wind.
That's such a good way to put it, because that's exactly what it is. And it's not like a breeze.
It's a hot wind.
It is blowing. Yeah, exactly. And the humidity is like 70-80%. It's just
I'm used to that. As bad as that is, I am. But the hot wind.
Yeah.
I remember having hot wind in Medford.
Yeah, that's what you're saying. That doesn't.
I remember hot wind.
Yeah.
I haven't felt hot wind in a long time. Yeah. All right. So what we're going to do is do a few cases, as I said, and I think this is a topic that I've wanted to do for some time. I think this is a topic that's highly testable on the FPC and CFRN, and I'm hearing a lot of feedback regarding that. And then getting a lot of emails, get tons and tons of emails about doing a review course for the Certified Neonatal Pediatric Transport certification. Obviously, I tested and got that about 18 months ago. Maybe it's been 2 years ago, but that's on our list to do. I'm very, very busy, obviously, and just want to thank everybody for allowing us to be busy.
Yeah. And pediatrics just in general give people a hard time, right? Because it's a low-frequency population that we see, and they have their own inherent issues. So that's why the pediatric podcasts are fairly popular.
Sure. So we're going to use some case application. I think that we learn best that way. I think our listeners have really grown to like that approach, and so this is a nightmare series case. We're going to use two specific cases that I've kind of researched and found out about, and these are more case-based journal type of cases. I've changed a few things just to apply to our audience. And hopefully we'll get through two cases and see how it goes.
Let's get into it.
So when we teach the review class, if you've come to our review classes, you know that the last day we do a neonatal lecture. I usually do that lecture, and I apply kind of the in-flight delivery that I was involved with about 5 years ago. And when we get to the very end, I can see the glassy eyes. There's a lot of stuff, and it really makes you respect those neonatal teams that they have to deal with some of these things. And if you've ever went to clinicals at these high-level Level 1 facilities that do these preemies, these 27, 30-week preemies, and they're taking care of them and doing all these surgeries, it's mind-blowing. It really is humbling to walk in and see these nurses and these doctors take care of these little guys.
Yeah. I mean, can you imagine taking care of a 2-kilo kid?
Yeah,
right?
It really is amazing.
Unbelievable.
So this first case is something that we all could experience. And there's a common thread with a lot of these heart defects is that they don't manifest themselves initially. These kids appear to be healthy. They appear to be normal, right? They're born usually full term. Obviously the preemies have underlying issues, but a lot of times with the technology we have now, the doctors already know these underlying issues. Yeah,
typically not a surprise, assuming that prenatal care has been, taken advantage of.
Sure.
And we know there's a lot of places around the country that it's not possible. So sometimes these things go undetected, right? So
yeah. So this patient right here is a family calls 911. We're talking rural southern part of the United States. Calls 911, full term, 40-week gestation baby. has been home now for 3 days, so the baby's 5 days old, and they note that the patient just had a sudden decompensation, had some central cyanosis. They noticed some bluing around the lips, the gums, and noticed that kind of spreading to the extremities, to the hands and the feet. So right peripherally clamped down. So they call 911. EMS gets there. Obviously 5 days old. They're probably a little out of their comfort zone, and they find this baby has CNS depression. Family states that the baby had some CNS depression on delivery. APGAR scores were about 3 on initial delivery. Had some meconium staining, so stressful delivery. And we have this decompensation. So I think we start out and we have to realize that a lot of times these neonates, these heart defects, we don't think we're ever going to deal with them. I think that's a misconception. We think that we're only going to see patients that are, over 40 weeks. We're not going to see these heart defects, but we have to remember they manifest themselves late. So what's our differential?
Well, it could be a lot of things at this point, right? I mean, we don't really know, but they generally fall into a couple of different categories. So it could be an infection, although that seems pretty low. I mean, I don't know if that would be the first thing on the top of your mind on a brand new baby, because that's typically not what you're going to see, but it could be certainly a respiratory issue, could be a cardiac issue. Given the fact that we're doing some kind of heart stuff, I'm going to go with probably a heart issue of some kind. Now, seeing how it's a cyanotic kind of presentation, my gut leads me to believe that we have some type of a heart issue. I don't know if it's tetralogy. Is there there's something going on there then that we need to look at?
Yeah, absolutely. So, I think all the three that you named are huge. And obviously, we've all learned that it's either respiratory or dehydration, right?
Yeah.
Right. It's a volume issue.
Right.
So we need to assess, has the patient been breastfeeding?
Yeah.
Has that been normal diapers, all those things.
Yeah.
Infection. You bring up infection. Infection is actually a very, very common thing. Usually the infection is going to manifest itself well before the 5-day mark. But babies that get septic, they get septic because the mom was group B strep positive. They didn't identify that. I think OBGYN, OB docs are good about testing the moms. And if they're
but again,
positive.
We're assuming that everyone gets prenatal care, which we know is not the case.
And so if they find that they're positive, they treat that. And a lot of times they find they test this, during normal prenatal care, and this is addressed. If it's not addressed, then that is passed to the baby, and that's the leading cause of neonatal sepsis. So we have to evaluate the kid for possible infection. I think that's always important. And I think that goes right along with our respiratory status, right, and our fluid status. So I think all those could be grouped in together. So obviously, you come on this kid, we need to evaluate the respiratory status. Are they lethargic?
Yeah, I'm going to be looking at that when I walk in the door, right?
Sure.
You do the pediatric assessment triangle, right? What's their level of consciousness, the best you can for neonatal? What's the respiratory status or their work of breathing, right? And you want to see what's going on. I'm going to assume that we're going to see a lot of that as we're going in the door.
Absolutely. And so if we evaluate respiratory status and then immediately evaluate their heart rate, right? So think about NRP, think about PALS. A 5-day-old heart rate, I'm going to look that up. That's not something that I remember.
That is another cue for having some kind of pediatric guide, whatever it is, length-based, weight-based, hand-heavy, whatever it happens to be, because we can't remember that stuff. And you got to know the normals before you have any clue when somebody's outside of those.
Yeah, so you get this patient, if this is a flight team that's taking this and you're a flight team listening to this, you don't get the information when you're toned, but once you get in the air and you get the report from your dispatch aircom center, they say you have a 5-day-old, pull your field guide out. I still carry the same field guide that I carried on the ground 15 years ago. I still carry the same one. There's a lot of stuff out of date in that thing, but I've got little things in there, and I simply use it for, honestly, the pediatric stuff. Just I want to know the heart rate. I want to know what their different parameters are. And there's tricks that we can identify as far as a shock state. Yeah. Remember, for a 40-week gestation, you can simply use 40 weeks. You can move the decimal over from the 0 backwards, and their ET tube size would be a 4.0. We can look at 40 weeks, and we can say their minimum MAP blood pressure would be 40. Or we can also use the blood pressure parameters of 70 plus 2 times the age. So that would be a minimum blood pressure. We would treat them with volume if their pressure was under 70 systolic, essentially, right, because they're less than a year. And then 90 plus 2 times the age would be their normal systolic blood pressure. So that we got a lot of little core resuscitation ways to evaluate the shock state in this little guy.
Perfect.
I think the thing that's alarming with this case is we get on a baby like this, and kids just, we know they compensate for a long time. Yeah. Why would a baby that would just completely decline like that was determined to be normal and healthy? And I think that's the scary thing.
Yeah, I agree.
Obviously, you need to check a glucose.
Yeah, right off the bat. I mean, that's going to be one of the simultaneous things we're going to be doing as we're going in there and doing our assessment, right?
Yeah. So you have a blue baby, right? They're cyanotic centrally. It's moving to the central core area. Probably doesn't always elicit. It's a blood sugar issue, right? But we got to rule that out, as you said. That's an important rule out. Yeah. So we got to remember a few core things. Is babies are born with a very immature, non-functioning hypothalamus. They have very, very little insulating fat, which is called brown fat. And so we have to realize that if we don't regulate their temperature, they're going to shiver. They shiver. They're going to spill glycogen and sugar. Their sugar is going to spike with any stress response. So even if you check a sugar and it's high, always expect that to fall.
Yeah, check that again.
Yeah.
Yeah, absolutely.
And so we know in neonates we're going to check a sugar, and if it's less than 40, we're going to treat that with D10. What do you recommend with D10? How do you have your guys?
Ours, we have it packaged. It comes in a 100 ml bag. It's D10. There's no mixing. In fact, we're giving D10 to our adults too.
Yeah, and that's great.
Yeah, D50s have kind of gone by the way of the dodo bird, so it's extinct for the most part in our system. So.
And what's your dose? Is it 1 to 2 mils per kilo?
Yep.
So 1 to 2 mils per kilo. So what would you recommend for our listeners out there that don't have pre-mixed D10?
Well, there's clearly best practices out there, and so there's lots of ways to do that. So some people take the D50, put it in a bag, and mix it up that way. Other people squirt out the D50 and then drop saline in there to get their concentration right. So whatever's going to work for you, that's going to be the biggest thing, because the last thing you want to be doing is trying to figure out math at 2 o'clock in the morning on a 40-week-old baby who's dying in front of you. So whatever method you guys choose to use, make sure you practice that, number one, and just be aware of the way you're going to do it. And don't guess.
Yeah, and I think that's a great point. I mean, I've always just done the D50, expel out 40 mils of that.
And just fill the rest.
Pull it up, and then you dose it at 1 to 2 mils per kilo.
That might just work perfect for people, and that's the typical way you do it, but at the same time, if there's a better way you can do that,
absolutely,
then you should do that.
Absolutely. So we would want to check a sugar, evaluate that, treat that if it's less than 40. We also have to remember that this child needs volume resuscitation. Whatever we do, we need to evaluate and get some type of volume on board. Still, 5 days old, they're going to be 10 mils per kilo, right? 10 mils per kilo.
Yeah. And of course, and just to kind of chime in on that, there's varying ways you can give fluid too. Some people use a Buretrol. Some people draw it up in a syringe, a larger syringe. Some people use a pump because it's super easy to have fluid run away from you, especially in a critical case like this. If you're not paying attention or you have other things and those human factors take over, next thing you know, you've run 500 or whatever it might be into a kid, and that's not necessarily going to be good either. So make sure you pay attention to the way you deliver fluid to people.
Yeah, and I had always been taught to use the Buretrol, and I would use the Buretrol to do that. Mm-hmm. And so, there's a way to give maintenance fluids as well. We need to always go with D5. Mm-hmm. D5, and we know that once that sugar is metabolized, that the D5 turns into water, right? So you get hydration there. And so we need to use that 4-2-1 formula. 4-2-1 formula is basically you take the first 10 kilos of a baby's weight, multiply that by 4 mils. That is the first segment of that. You take the next segment from 10 to 20 kilos of their weight. You multiply that by 2 mils. Add that. And then you take the last bit, anything above 20 kilos, you take that and you multiply that by 1 mil. Add those two together, and that's how many mils per hour they receive. And really, that should be any pediatric. And a pediatric is truly up to 17 years old, right, before their 18th birthday.
Yeah.
The next thing I want to kind of think about is, why is this baby all of a sudden cyanotic? So there's lots of reasons, and we're going to get into the cardiac causes. But one aspect is, if you think back to the stressful delivery, APGAR scores were low, CNS depression on initial delivery, right? Meconium staining, which we got to remind people, if you haven't taken NRP, that NRP is much different than PALS, and NRP really dictates the critical care environment. Like, we don't suction babies' mouths and nose anymore. The only time you do that is in a severe stress meconium staining. We don't just give prophylactic oxygenation, right? Things like that. But one of the things that can happen is these babies can be polycythemic. And what happens is that if the newborn, let's say there was a stressful delivery, if the newborn receives too much blood from the placenta at birth, so this may occur if the baby is basically held below the level of placenta.
Gotcha.
And so basically you have a placental transfusion of the mom's red blood cells. And so this is no different than we see in COPD patients that produce high amounts of red blood cells in an attempt to increase their T3-DPG so they can have good offloading. Well, that causes a polycythemic effect as well. So they become hypoxic because not everything's saturated, right?
Yeah.
You have a big discrepancy between your red blood cells and your hemoglobin.
Yeah, and there's just to throw this out there to kind of set up the next point is that there's a big difference in fetal hemoglobin and kind of everybody else's hemoglobin, right? So do you want to talk a little bit about that? And I'm not because one of the things about fetal hemoglobin is it's not like once you're born, all of a sudden this magic thing occurs and that's gone. So that lasts a while. So how does that going to kind of play into what we're dealing with here?
Well, in this patient, if this was an underlying polycythemia, which, that's just a suspicion,
Right.
There's no way in the field you're going to be able to identify that,
No,
obviously. But I think that's a great point when you think about what's the difference between fetal hemoglobin and adult hemoglobin. And we got to remember, fetal hemoglobin has a very, very high affinity for oxygen. So if you think about the oxygen dissociation curve, and we evaluate right shift and left shift, if we want to recap that really, really briefly, remember a normal curve means that there's a good relationship. You have oxygen that binds to hemoglobin. That hemoglobin releases that if the body needs it, right?
Yep.
If we have a right shift, we have a situation where we see this in homeostasis in our muscles, right? Our muscles are always warm. They're hot, right? So a hot temperature. Or a hyperthermic patient, a patient with a high metabolic rate, raised acid. So we think about our muscles as well. Our muscles, in comparison to oxygen, have a lot of CO2. They have a lot of buildup of acid. So our muscles, or an acidotic patient. Patients with high amounts of 2,3-DPG, which is that molecule attached to red blood cells that pops the O2 molecule off, right? That little crowbar. And that's how our body gets oxygen that's transported in our blood off the hemoglobin. And then we have a phenomenon of high partial pressure of oxygen in our bloodstream, in our plasma. And so what happens in a left shift is we have a high affinity. Oxygen binds to hemoglobin, and hemoglobin doesn't want to give it up. So that's exactly what fetal hemoglobin does. Fetal hemoglobin is very, very sticky. It loves oxygen and doesn't want to give it up. And so our babies are living in a left shift during that gestational growth, and it allows for great oxygen pickup. The difference is that the 2,3-DPG that we see on the red blood cell, it doesn't interact well with fetal hemoglobin. And that's why you have poor unloading. But our mom is doing all the oxygenation, right? I mean, and so in contrast, the mom has to be opposite. The mom is actually living with a low affinity for oxygen. So they can unload their stores, right? The baby needs it. Placenta needs it.
Yeah.
And so their 2,3-DPG is increased because our red blood cells are increased. They have a very, very awesome way of unloading oxygen. And because we unload so much oxygen, they have a high partial pressure of oxygen. So whenever we teach the review course, I always point out that a pregnant mom, you always optimize oxygenation. You never withhold FiO2 to a mom that's in trouble. It's a trauma patient, any medical-related problems, because if their partial pressure of oxygen drops down to less than 90, which is perfectly normal for you and I,
there's major downstream effects.
Absolutely. Yeah. That can put them into preterm labor alone, is that. So we have kind of a contrasting aspect. Our mom has a very low affinity for oxygen, for hemoglobin, so that means that we're unloading it, and the baby has a high affinity, right? And it makes a perfect kind of downstream effect where everything works out perfectly. So I think that's a very interesting thing. And we got to remember that we carry 98% of our oxygen stores, which is a huge, massive amount, on our hemoglobin. Only 2% in our plasma. So with our mom's ability to deliver all that oxygen, we know their plasma concentrations increase significantly, 40%, and red blood cells, all that really increases in that pregnant setting. So if we continue and we kind of look at maybe assessment pearls, we need to obviously identify their heart rate, identify what's going on. And so, this little guy, heart rate wise, is 164.
Okay, that seems reasonable to me.
SpO2 is 70%.
That kind of freaks me out a little bit. Even though he's 5 days old, I feel like it should be a little bit better than that. Now, I realize when these kids are born, it's going to take a while for them to kind of get their sats up, but I'm not super happy with that number right now.
Yeah, and if we go back to NRP and we kind of look at what NRP says that at basically the 4 or 5 minute mark, they should be about 75, 80%. I'm just going off memory, but that is at 5 days they should be absolutely fine. At 10 minutes they should be 85 to 90%. So, 70% on this baby is abnormal. And so we have to identify, if heart rate is 164, we don't have a cardiac output issue at this point. But why do we have a sudden spike? Right. So assess, obviously we already talked about the fluid status and stuff like that. So let's talk about a term that's pre versus post ductal.
Okay.
What does that mean to you?
Well, we're talking about the ductus here.
Yep.
And so I'm going to assume that's at what point is the cyanosis occurring? Is it left-sided, right-sided? Where's it coming from, right?
Yeah.
So that's what I would say.
Yeah, so we always want to assess a neonate and identify their SpO2, but we got to make sure we identify it in the pre-ductal point. So that's a very key thing when you assess these kids, is always make sure your SpO2 probe is on the right hand. It's got to be pre-ductus.
Okay.
Right? We also have to realize what happens when we're born, right? When we're in utero, we're a primary high-pressured right side, right? The way blood travels through the liver up through the foramen of ovale into the right ventricle. So that whole right side is your high-pressure side. That's
where the work's getting done.
Absolutely.
Left side's just hanging out, thinking, man, things are good right now.
Yeah, and when we're born and we start breathing oxygen,
first few breaths,
it switches back over. It switches over, right, to where we're a left-sided dominant.
Yeah. Hopefully that ductus closes and everything goes back to normal and we're good to go.
Yeah, and we're going to hit on that specific aspect of how long does it take for the ductus to close and different things in a little bit. So pre-ductus, again, is right hand. Post-ductal is going to be left hand. So our pre-ductal, we want to do assessments of blood pressure.
So we want to do one on the upper extremity and maybe one on their leg or something?
Yeah, absolutely. Okay. So evaluate, what do we have? Because what you can identify there is, do we have an obstructive process? We're going to see that there's different types of heart defects. And so if we have an obstructive process, what you're looking for is you're going to take a blood pressure on the upper extremity, you'll take a blood pressure on the lower extremity, and then you evaluate what the difference is. And if you have a difference of greater than 10 millimeters of mercury, right, the lower is basically 10 different than the upper, then you have a definite obstruction process. So when I mean by obstructive, most often it's going to be an obstructive process on the left side of the heart. So we're thinking about, do you have a correctation of the aorta, a narrowing of the aorta, or a aorta that's stenotic? Yeah, something like that. So that's where we get into evaluating the color, right? There's 3 colors for neonates that warrant kind of further investigation, and the first one is pink, right?
Yeah, that would be my preferable color if I'm going. Yeah.
But does pink always mean good, right? Maybe, maybe not. What if they're blue? He's blue.
Yeah.
Or what if they're gray?
Seems like it'd be hard to distinguish, not having seen that, the blue from the gray.
Yeah.
I mean,
so is gray
is it
like a chest pain guy that's just like gray?
Just looks like crap,
you just walk in and you're like, oh man, this isn't going to go well.
I've seen gray. I guess just not in terms of a neonate.
Right. So let's talk about pink.
Okay.
Pink is going to be a shunting issue. So they're pink because they have adequate pulmonary blood flow.
Okay.
So these are what's called acyanotic heart defects. And we talk about this in the review class. We categorize these as acyanotic or cyanotic. So acyanotic heart defects are specifically a PDA. You have a patent ductus that has never closed.
Yeah.
Or a ventral septal defect, an isolated ventral septal defect, or an isolated atrial septal defect.
But can't you have some venous mixing in that case as well? I mean, they're not. So when you're saying they're pink, are they always pink? Or are they going to have little short episodes of where they might be blue or gray and then they're pink again?
I guess they might have a little bit of central cyanosis at times.
Yeah.
And I think that's going to be based on more the ventral septal defect, how big those are. I think when you look at pictures in textbooks, they'll put this big, huge, massive hole there.
Right. So
and from my reading, it looks more like a cheese grater. Itty-bitty holes.
Oh.
So I think it's in our mind. We think we have this massive hole. Right. So is that mixing as bad as it seems on a picture? PDA. Oftentimes PDA is just an isolated PDA where that ductus doesn't close. That ductus should start closing in 24 hours. Sometimes it takes a week. If it takes longer than a month, right, there's a problem, right? They may need help. But what will happen, we often don't think that that's a big deal, but if you have extra blood flow because of that PDA being patent, it's going to cause a hypertrophy of
that makes sense.
Your ventricles, right? And so you can have backflow. You can have CHF from that. These kids will get pulmonary hypertension, and they'll be very, very sick. And so we have to remember that lungs that get filled with fluid, think of them as a wet sponge. You can't ventilate them very well.
Yeah.
And so we have to definitely realize that a PDA is a serious thing.
Yeah.
If we move on to a blue baby means they have a right-sided obstructive type lesion. These kids are what's called ductal dependent. And so there's 3 of these that specifically look at and are categorized as a cyanotic heart defect. So we just looked at acyanotic heart defects, and that just means that an acyanotic heart defect, they're not dependent on ductal flow. If the ductus closes, we're still good, right? And a cyanotic heart defect means that we've got to maintain ductal flow. And what's causing the decompensation is actually that ductus closing. So if we go back up to this patient came home, was perfectly fine, no signs or symptoms of any problems, right? Because the doctor's not going to send him home. Mm-hmm. But what happens about day 4, day 5, that ductus closes. Yeah. And so imagine that they had tetralogy of flow. Or what if they had a phenomenon called transposition of the great vessel, where your aorta and your pulmonary artery grow in the wrong spots. They basically flip. Or the worst of all worst is a hypoplastic left heart.
Yeah.
So if you have a patient that presents all of a sudden decompensated like that, it's because of that ductus has closed, and that was the only thing allowing oxygen-rich blood. Or in some cases, that was the only thing that was allowing a release of pressure. You'll see that same phenomenon in a coarctation of the aorta, that narrowing of the aorta. Once that closes, you already have a narrowing. That's going to be backed up in the left ventricle, up through the mitral valve. You'll have a mitral valve issue, just like a 80-year-old CHF.
Absolutely.
Right? It's exactly the same. So one of the things that we need to identify in these kids is, it's probably the last thing we think of. You're transporting this little guy. And again, this is critical care, and I'm just going through all these different treatment parameters, right? Think of yourself as a neonate transport team. And I truly believe, and Mike and I have talked about this before, if you think of these little kids as adults, right, it's almost a mind game. And I think you really have to almost tell yourself, hey, I'm going to treat this kid as an adult.
Yeah. And I think, and it's funny, one of the things that in my opinion, this is just Mike Verkest's opinion, but I think that's one of the reasons why Peter Antevi has been so successful with his kind of take on pediatric resuscitation, critical care, newborn stuff, is just exactly to your point. What you're saying is we have to, because that's born and bred into all EMS providers. Whether it doesn't matter if you're critical care, you all started off, unless you're in the nursing side, but for the most of us, we started off as EMTs. And that was one of the things they told us, that they are not just little adults at all. And so that's ingrained in you throughout your entire primary EMS education. And that's the way you start thinking about stuff. But I think you're spot on with the fact that, you know what, the things we're going to be doing are a little bit different. But it's a mind game. I think you're right on with that.
It's because of the innocence. It's because they're fragile, they're little, they're precious. I get that. Mm-hmm. So important aspects to kind of understand with regards to the cardiac aspect is everybody's favorite subject in axis deviation.
I know it's yours.
I like me some axis deviation.
I know you do. Your brother nerds out on that.
Yeah. I nerd out on a lot of stuff.
That's okay.
It's all right.
This is one of them.
But when we think about axis deviation, we know that an adult patient is going to have a normal axis. And essentially axis deviation, the normal axis, means that they have their primary impulse is moving towards the apex of the left ventricle. Mm-hmm. That's essentially that area, right? I always think of it as that area of the heart needs the most energy, right? Our standard conduction system moves that direction. We know that if the axis turns to the left, our axis is kind of pointing up towards the aortic arch, the aorta there. Maybe we have an issue with afterload, and left axis deviation is associated with patients that have left ventricular dysfunction, right?
Makes perfect sense.
Right axis deviation is just the opposite. We have a right-sided heart failure, right ventricular hypertrophy, portal hypertension, liver failure, right? So that axis shifts to help that area. Well, when little babies are born, they're born in right axis deviation. And I think that's not something that's commonly understood. Yeah. And the reason why they're right axis deviation is think about a pulmonary embolus. I talked about this today. Pulmonary embolus and the 12 that I showed had the classic right heart strain, S1Q3T3. Mm-hmm. We know that it's not a absolute definitive diagnosis, right, but that was in a right axis deviation. And so these babies are high pressure right side. So due to the high pressure on the right side, 100% normal to be in right axis deviation. And they also have a phenomenon where they'll have a positive T wave in V1. Okay, that's absolutely normal. In contrast, if you ever have a baby that's born and they're in left axis deviation.
That's what I was going to say. So then I'm assuming anything other than right is probably potentially not a good idea.
Yeah, specifically left axis deviation is absolutely bad. It's always bad. Should never see left axis deviation in a baby, and usually attributed to a hypoplastic left heart.
I was going to say, does that help you somehow kind of narrow down some of the issues that the child might be having if you happen to run that 12 lead and find out they're in left axis deviation? Does that help you kind of narrow in that something else is going on here?
Yeah, so think about a hypoplastic left heart. A hypoplastic left heart, essentially these kids are born without a left ventricle or a very, very tiny left ventricle. Yeah. So they have a dominant right ventricle, they have a normal right and left atrium, but their left ventricle is very, very small. So these kids do not do very well. I think the science is improving. Yeah. If they do make it through the first stages, it's a multi-step surgery based on age to basically get them to heart transplant most often.
Yeah, there's some really good videos on YouTube that show and actually share some stories from kids with HLH and kind of their journey and the parents' kind of interaction and stuff like that. It's pretty interesting stuff.
Yeah, that's awesome.
Yeah.
All right, so let's continue. Respiratory depression, right? Why would we have respiratory depression, right? Baby had respiratory depression on initial presentation when the baby was born. Respiratory depression on decline, and so we have to evaluate. Now we kind of have to make a decision. Is this a pink kid, right? Shunting, have adequate blood flow, right? So remember, these are acyanotic in nature. So PDA, ventral septal defect, atrial septal defect. Or is this a blue baby that has a right-sided obstructive lesion like tetralogy of flow, transposition of the great vessels, and hypoplastic of heart? Tetralogy of flow is one of those diseases that is pretty profound. And essentially what you have is you have blood that comes into the right atrium, passes through the tricuspid valve, and when it moves into the pulmonary artery through the pulmonic valve is diseased and stenotic. And so what happens is
creating a back pressure.
Absolutely. So the only where it can go is go into the right ventricle. And these patients also have a ventral septal defect. So not only does it make the right ventricle enlarged, right? So you have right ventricular hypertrophy. So you're going to have that right heart strain. But then we have mixing of deoxygenated blood through the ventral septal defect. And so these kids will be very, very hypoxic.
Yeah.
So what these kids will do is they have to, when they become agitated, they become fussy. That's where they're going to have that hypoxia. Yeah. And so if you make them cry, or you try to get them to cry, or they cry.
Or they cry on their own.
Right.
Or older kids, they'll squat down.
Yeah, absolutely.
Increase
They'll squat
pressure.
down to kind of bring that pressure up. So that's tetralogy of flow. So they'll do a multi-step surgery to, number one, fix the pulmonic valve. Then they're going to patch the ventral septal defect. But these are cyanotic heart defects. And so these heart defects are dependent on PDA patency. And I think that's the key.
All right, so let me ask you this then. So going back to our case, we do our initial assessment. We walk in. We're looking at this kid. Looks like crap. After a few minutes, kind of hearing what you're saying and knowing how kids can have sort of spells and they might look better at times than others, is there any difference when we do our secondary assessment on this kid, right? We've gone through, checked the sugar, done all the stuff, maybe started a line, try to get some fluid on board. Is our kind of ongoing assessment revealing anything different about the kid?
Yeah, during ongoing assessment, you notice that SpO2 is still 71%. Heart rate is about 155. And you notice that the little guy is looking more gray.
That's not good. Blue to gray. All right.
Yeah.
So a lot of times I will just tell you that, coming from the ground side, I think one of the first things they're going to do is whip out that oxygen tank, right? That's what they're going to do.
Yeah.
And they're going to get a non-rebreather, and they're going to do blow-by or however method they're going to try to do that. And it's probably not necessarily a good thing, even though I get that. I mean, I understand why they would do that, but that's not going to be super helpful in this case, right? It can actually be harmful.
Yeah, so if we go back to resuscitation points of just a standard newborn, right, at 1 minute, their SpO2 pre-ductal, again, it's got to be on the right hand, needs to be between 60 and 65%.
Yeah. And we need to not freak out about that. That's okay.
That's all right. Absolutely. Yeah. If it's 60 to 65% and their heart rate's appropriate, we don't do nothing.
No.
We just leave it alone. Yeah. And that is going to ruffle people's feathers, right?
It does.
It's just because it's not intuitive. It's not what we've been taught, and I get that. At 3 minutes, 70 to 75%, right? We're still like
we're still a little itchy with that one.
So essentially at 3 minutes, if they were less than 70%, then absolutely give them a little oxygen. But I would probably try positive pressure ventilation, and see what that does. At 5 minutes, 80 to 85%. Right? So that's for a newborn. And there's two reasons why that is appropriate. Is number one, we don't want closure of that ductus
for the reasons we just talked about, right?
Yeah, let it close naturally. Giving high concentration of oxygen closes that very, very rapidly. The second reason is if we give lots and lots of oxygen to these kids, number one, they can't handle it, and it causes retinal detachment. It'll cause blindness, right? So that's a very, very bad thing.
Yeah.
So now that the baby is kind of looking a little gray, right? We evaluated our blue color, right? Those are our right-sided obstructive lesions. So again, ductal dependent. The next thing is gray, right? Why are they gray? And so let's look at that. Gray always means a left-sided obstructive process. So again, we started with pink. Pink is they got good pulmonary flow. They're not ductal dependent. The blue and the gray presentations are ductal dependent. So we have to make sure that ductus stays open. So your question on oxygenation is a great one because that's what we're all taught to do. Mm-hmm. But again, this will make this kid decline and get worse. And the reason why is on a gray kid, we got to know that this is a left-sided obstructive process. So the two main presentations are going to be coarctation of the aorta. So that's essentially you got the aorta that comes up, that ascending aorta comes up, and we have a narrowing. Like imagine putting a ring around a balloon and then putting water in that balloon. That's exactly what it looks like. So when that ductus closes at that 5th day, all of a sudden, as I said before, we have a back pressure of blood that goes into the left ventricle up through the mitral valve, and we have associated pulmonary edema and CHF, pulmonary hypertension. If we give this kid oxygenation is a very potent vasodilator.
So you're saying it's a medication?
Absolutely.
I say that as a jest because we just give it out like it's, free.
Yeah, that's a good point.
We do.
So if it causes potent vasodilation, think of what that's going to do to pulmonary blood flow. Pulmonary blood flow is going to flow into the lungs, and it's going to cause a worse shunt, right? It's opposite of what we want. And that's where we have to, quickly identify. So coarctation, or if you have aortic stenosis, right? If that valve is stenotic, right? You're going to have that phenomenon. So when we look at kids and we're like, okay, how do we evaluate this? Basically, a kid that's less than 2 weeks old, if they decline like that, it's probably a ductal lesion. The literature says a month old, but a more conservative, so you don't miss things. If they're less than 2 weeks, it's a ductal lesion. So that closes within 24 hours more often, as I said, but it can be as long as a month. So coarctation, aortic stenosis for this. So we looked at blue, we looked at gray, and we got to have ductal flow. We got to keep that thing open. So the treatment for that, and obviously on the ground side or even the aeromedical side, you're not going to have access to this, but the kid has to have prostaglandins. So prostaglandins are dose-dependent, response-dependent. You're going to start at a lower dose. It's going to be 0.5 to 1 mic per kilo per minute. And then you're going to just give that based on how the baby's doing. One of the misconceptions that you see on advanced certification exams is that any prostaglandin administration is going to cause apnea, and that's not the case. Normal low doses, there's no apnea involved. You always need to be cognizant. You need to have a ventilator at the bedside. You need to have your intubation stuff ready to go because it could happen just instantaneously, right? Every kid is going to respond a little differently.
Yeah.
As we said, all kids are born with right axis deviation. And so in this case, if we said the baby is now gray, we only have two choices. We have coarctation or aortic stenosis. Coarctation is probably the one it is. So think about a patient, if they have a right ventricular hypertrophy. Right ventricular hypertrophy is going to show up as positive T waves in V1. It should go away after 1 week. So after 1 week, if your T waves are not down, you still have that right ventricular hypertrophy, right? And so why would that manifest? Another thing that we have to kind of consider is looking again at that T wave in V1. As I talked about before, that T wave in V1 is a normal finding, right? That's due to that right axis deviation. You should have that positive T wave in V1, but that should actually go away after 1 week of age. And so if it does not go away after 1 week of age, that is indicative of right ventricular hypertrophy.
That makes sense.
So in this patient, we do a 12 lead and we say he's got a positive T-wave in V1. Well, he's not quite a week yet.
Yeah.
So that's kind of hard to identify. But we do know that coarctation of the aorta, basically, you'll have a right ventricular infarction because you have a left to right shunt. And so that coarct has to push really hard to get that blood to the left side, right? If you have a river, you know how I draw on the board.
Oh, I know.
You got that river.
I know.
I got a better river. I've mastered that thing. If you got a river coming in,
Yeah.
and then you got that river going into the lungs, into the lake, which is the left ventricle.
Mm-hmm.
Well, it's got to push against that narrowed area of the aorta, right? That pressure is going to be exerted backwards.
Yeah.
So that's where it causes that right ventricular hypertrophy.
Mm-hmm.
So I think this case is one of those cases where you're going to take them to the most appropriate facility. Obviously, if this was an air medical call in the area I fly, I'm going to take this patient to Kozer Children's Hospital. I don't care where I'm at. I'm going there. There's nobody else. I shouldn't say that. I guess I would consider Vandy Children's and things like that.
Yeah.
But would probably go there.
Yeah. I guess the point is you want to get them to the correct destination the first time, right? Because we don't want to be screwing around with secondary facilities and having to worry about another transfer at another time. Let's get them to the right place the first time.
Well, let's be honest. You take a little guy like this, it's a ductal lesion, heart defect, they're going to crap when you walk in the door, right? So we have to try to get them to the most appropriate facility, even if it lengthens transport time, maybe 10 minutes. I mean, it's important. Yeah. So I think that's a great example of going through the different types of presentations, right? We're going to have to treat what we see. The key treatment points here are no oxygen. If you identify a blue or a gray baby, you do not give them oxygen, right? You need to evaluate. You have an SpO2 of 70%. You need to leave it there. Mm-hmm. Specifically, if you think about a hypoplastic left heart, they'll actually do gas mixing to bring that FiO2 down less than 21%, just so you don't have this issue because you have such a back pressure. Think about no left ventricle or a little, itty bitty freaking acorn. Yeah. That's all you got. Yeah. So that's where we look at that. All right, let's go to case number 2.
Let's do it.
Case number 2 is a 2-week-old full-term neonate. Parents state that the patient vomited a few times and has poor feeding. The poor feeding has been over the last 8 to 12 hours. If they really think about it, they kind of say, they feel like the baby's maybe lost a little weight, and the baby's gray in appearance. So we go back to our colors, either pink, blue, or gray, right? Blue and gray are ductal lesions. They need PDA patency. Yeah, absolutely. Yep. One of the things that I've read is, and it's so true, is that if we do things continuously, we become better at doing things. And me not flying, I go through periods where I'll fly, full time for 3 years, and then I'll go to education, right? And so everybody knows that I've moved out of those roles, and now I'm flying PRN. Yeah. So you go and you have a patient that is crashing. So that trauma patient I had last month. Heather and I were sitting there, and there was something that I noticed, and I said, well, I wonder if we have a pulse, right? And I'm trying to feel for a pulse. And if you don't feel for pulses a lot, you get kind of rusty feeling for pulses.
Yeah, I can see that.
I mean, let's just be honest, right? And so I think that that's an important part of our normal everyday assessment. These kids... we need to be able to check our pulses on these kids, and we know that that's not natural, right? So we have brachial pulses.
Yeah, we're not checking them in the normal spots.
Yeah,
right.
Can you check a femoral pulse on a little baby?
Oh lordy,
yeah.
I'd be hard pressed to honestly. Like in most adults, you can get it, but you gotta dig a little bit. I mean, you know where it should be, but then you start questioning yourself. Oh, am I feeling that or not? But I could not imagine in a 2-week-old trying to do a reliable assessment of a femoral or brachial pulse.
Yeah, and really when you think about pulse checks, femoral pulse is the best place to check.
Oh, absolutely.
So
proximity to that.
I think I heard a doctor say that you should check a femoral pulse on every patient. It's no different than me saying you listen to lung sounds in every patient. Yeah. If you become good at it, you're going to be confident in what you're feeling. And so for this baby, and that's something we could have added in the above case, is check your pulses. How do we evaluate an adult patient with a thoracic aneurysm?
Above and below.
Absolutely.
Yeah.
So we're going to check for pulses in the arms. We're going to feel blood pressures, auscultate blood pressures, and see if they're equal. And then for AAA, always check pedal pulses, make sure they're equal. Well, it's no different in these kids. And so we would check a femoral pulse. And so on this kid, right, you check a femoral pulse, you check your brachial pulses, and you essentially have no femoral pulse. Okay? So we have no femoral pulse. So what does that mean? That means we have an outflow obstruction automatically, just like we did before. We checked blood pressures, right? And we had blood pressure that was lower on the lower extremity, higher on the upper extremity by 10 millimeters of mercury.
Right.
That's an outflow obstruction on the left side. So something on the left side is causing the blood to not get through, right? Not pass. If we do a full assessment, we notice that the baby's abdomen is distended. So obviously, in that sense, we want to rule out: is there any abuse? Remember that the spleen and the liver are very vascular in neonates, very large in comparison to their stomach. So very easy to damage those in a traumatic issue. And so I'll tell you that I'm not good at palpating the abdomen.
Yeah,
I can't.
I was kind of the same way.
I can't tell you if a liver's enlarged.
Yeah.
Ashley's good at that.
Well, yeah. Well, she does that all the time.
Yeah, absolutely.
Yeah.
So I think there's something with that liver. If it, I don't even want to say it because I don't even remember right. But it's like 2 centimeters from the lower costal angle of the ribs or something like that. If it's beyond that, it's enlarged liver. And don't take what I just said, but it's something like that. You have to be able to evaluate enlarged liver.
Makes sense.
Well, if we have an enlarged liver, we have no pulses in the lower extremities, right? That kind of confirms we have an outflow obstruction problem.
That makes perfect sense to me.
So again, the most common is that coarctation of the aorta, as we just talked about before. So again, limit O2. Limit O2, and remember, we have an outflow obstruction, and so that blood is going to be backed up into the pulmonary vasculature. We're going to have pulmonary edema and CHF. These kids have a very high pulmonary vascular resistance and a very high pulmonary hypertension. So medications we need to start. We got to give them a phosphodiesterase inhibitor, and that's going to be milrinone. Right, milrinone acts on calcium channels, affects our contractility, affects our vascular tone. Very good at opening up those vessels. So we see that in CHF patients and adults as a fourth-line medication, but in pediatrics we see that in these pulmonary hypertension cases like this.
So these kids would get prostaglandins too, right?
Yeah, absolutely, right, because this is a ductal lesion.
Yeah.
Got to maintain ductal flow. So remember, prostaglandin is at 0.5 to 1 mic per kilo per minute. And another medication we could consider, right? We're not going to carry this, but Viagra. Right? Viagra is a phosphodiesterase inhibitor as well.
Something that I would have thought of right off the top, but that makes, again, good
same
sense.
exact thing. And so Viagra is very commonly administered to these kids.
So let's say we get this kid to the hospital. They're going to work him up, do some stuff. They're going to do a chest x-ray on this guy, right? So what do you think? I mean, what's that? What do you think we would see on there? It could the range could be all kinds of stuff, but what do you expect?
Well, the most common thing, if you have a coarctation or you have an outflow obstruction like that, whether that's coarctation or hypoplastic left heart or something like that, is going to be kind of that whiteout, right? We talk about this in our adult patients, that whiteout condition,
ARDS.
That ground glass appearance.
Yeah.
Well, can you evaluate, is this a CHF issue or is this an ARDS issue?
Yeah.
Right? Any neonate that decompensates, we have to always suspect sepsis. And they're going to work these kids up as sepsis. I guarantee it. They're going to give them prophylactic antibiotics and make sure that we don't have some type of ARDS sepsis-related thing. Was the mom group B strep positive, right? So you have to err on the side of caution. So in the adult population, we know that our kids, or I should say in the adult population, we know that we go through kind of a step-by-step approach. You can utilize a pulmonary capillary wedge pressure. We know that 18 is that high number. If it's greater than 18, then we have CHF, right, or a high probability of CHF. We also know that we can look at a PaO2 FiO2 ratio. You can divide your PaO2 by your FiO2, and if it's greater than 300, we're we're good, we're normal. If it's less than 300, we're more of an acute lung injury and inflammatory response. If it's less than 200, it's ARDS. So that's another confirmation of kind of looking at that ground glass appearance or that pulmonary edema. And you'll have those bilateral infiltrates oftentimes as well. And so this kid, vital sign-wise, we have a blood pressure of 67/30, heart rate of 156, respiratory rate of 60, and SpO2 of 70%. So, blood pressure. We said 70 plus 2 times the age is our low end of systolic. So we're definitely lower than that, just barely, right? Heart rate is
probably
a little high.
Probably in there somewhere. How old again did we say? 2 weeks?
Yeah, 2 week old.
Yeah.
But vomited times 2, so we need to always look at
absolutely his fluid
that
status.
Poor feeding, right? Why are we having poor feeding?
Check the diapers. What's going on with those?
You know, one of the things I always consider with poor feeding also is corneoatresia, right? Do they have a bone in the back of their nose? Usually that's going to be a unilateral issue. If they're bilateral, it's probably going to manifest pretty quickly. They can't breathe out of their nose when they're breastfeed.
So they're not going to do that.
They're not going to do that.
They're not going to feed, yeah.
And so, you know, something to just consider and throw in there. That's always something to look at.
Yeah.
So do we intubate this patient, right? And I think that's the key thing is utilizing your weight-based guide, utilizing, you know, the hand-tibby system. And I think that's where his system, I think, is so great.
Yeah.
And
which is his is an age. But the point is you have to use something.
Yeah, so utilize that and evaluate. And as I said, there's little tricks. If they're 40 weeks, you know, basically move that decimal. It's 4.0. Get one smaller and one bigger. Right? It's probably not going to be bigger, but get a couple sizes. Be ready. And if you do intubate these kids, one of the medications we kind of want to stay away from because they're already hemodynamically kind of on the edge is ketamine. And I can't even believe that's coming out of my mouth because I love ketamine so much. But we know ketamine causes a stimulation of sympathetic response by blocking muscarinic receptors. Muscarinic receptors are your parasympathetic receptors. And so these kids can't handle that up and down of hemodynamic changes. Yeah. So etomidate is actually going to be maybe a better choice. Yeah. So we intubate them, right? Utilize good technique, utilize your securing techniques, confirmation with end-tidal CO2, and then, you know, go from there. You know, coarctation of the aorta is the diagnosis for this kid, just like the one before. And coarctation, again, is going to be a multi-step surgery to basically dilate that area of the aorta. They may put a sheath in, like a stent, to do that. Yeah. And then once this is all fixed, they'll give the patient a drug called indomethacin to close that ductus, and that way they'll be back to normal. So very, very cool. One of the really cool disease processes that I find very, I guess, fascinating, and you can put this on YouTube and look at it, is the transposition of the great vessel, as I said, is you got to remember this: neonatal hearts are the size of a walnut.
Yeah.
And you have a phenomenon where your aorta and your pulmonary artery, as I said, grow in the wrong spot, and your coronary arteries grow in the wrong spot as well. Some of these kids actually have just one dominant coronary artery. That's it, right? So they have to manufacture these coronary arteries. They have to dissect them off of the pulmonary artery because it's not in the right spot. Then they have to switch those vessels. It's called a atrial switch. And then they dissect those. Those coronary arteries are only 2 millimeters in diameter.
Yeah, that's pretty much. I took your advice and
Did you look that up?
A couple of those videos on there. It's unbelievable. I mean,
yeah.
I think a walnut is probably giving it a little too much credit at some of the time. These hearts are small, more like an apricot. I mean, something small, right?
Yeah.
It's pretty amazing.
Yeah, for them to dissect those off?
Yeah, doing work on that. I mean, it's one thing that it's so small, but actually getting in there and doing this microscopic vascular surgery is
then they got to sew a 2 millimeter vessel back on the aorta. Those are some small stitches. So I find it very, very fascinating. Yeah. So I think, that's really all I have for this podcast, for these cases. I think, we went through the different heart defects, ductal heart defects, kind of going through the assessment, looking at some presentations. I think the thing to remember is we all could go on a call tomorrow with a kid that is discharged full term and they decompensate like that. Remember, if it's a blue or if it's a gray presentation, they decompensate because that ductus closes all of a sudden, right? Or it's basically at that point where it closes.
Yeah.
And that's why they decompensate. And so we have to be good detectives. We have to treat them as best we can. And, just think of them as adults, right? Kind of trick your mind and prepare. If you want a really good app that I was just introduced to, I've kind of played with it a little bit. It's kind of cool. It's called Heartpedia. And Heartpedia is put out by Cincinnati Children's Hospital. And so I found it very, very cool. You can actually, turn these hearts and flip them around in 3-dimensional, and you can open them up and look at the inside. It'll show a normal heart. It'll show a heart defect heart. Mm-hmm. So if you really want to kind of study up on this stuff, check that app out. And that's all I have. Do you have anything, Mike?
Nope, that's it. Thanks for having me on the FlightBridgeED Podcast. I always love coming on and making an appearance, and it's always good stuff. So thanks again, buddy.
Hey, I appreciate you doing all you do. Again, check out the Fast 18. Just signed a pretty awesome keynote speaker. Yeah. I'm pretty.
This is pretty unbelievable, actually. I am blown away. I cannot wait to hear this guy. Yeah. But we're going to keep you in a little suspense. But
it gets me emotional thinking about it. It really does. It's going to be really, really cool. So remember, tickets are going to be limited. I think we're going to raise the number to 350. But
that's the number of people that can attend.
That's it. Yeah. And so get your tickets now.
Yeah.
And they're going fast.
They are selling pretty consistently. Yep. So that of course that makes us happy because we want to put on a good show and be able to have that revenue to do that. So thank you for those of you that have jumped on and ordered tickets. It's phenomenal. We appreciate it. But don't delay if you're thinking about it. I know some of you are waiting for a venue and a schedule and all that stuff, and I promise you it's coming soon. But I also promise you won't be disappointed. So jump on there. I mean, if that's what you're waiting for, at least get in there and reserve your Fast 18 tickets because you will not be disappointed with the program. It's going to be pretty awesome.
Yeah, we'll put out a newsletter coming up this week. We did finalize the last little bit on the venue, and we do have a block of rooms for the hotel that you can get a discount on. Yep. So I'll release all that information. Evan will actually put that on the website. I think they're going to give us a link to where you can click on that link and you can reserve your room straight from that link and get that discount. So on behalf of Mike, I just want to say thank you again for all the great emails and following, and hope to see you at a review class soon. And we just thank you so much, and we'll talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.